Welcome to the voiceover on fetal heart rate assessment. In this voiceover, we're going to cover the basics of fetal heart rate assessment and what you as the nurse would have to do in response to changes in that fetal heart rate assessment. Fetal heart rate assessment can be done in two different ways. You can have intermittent auscultation. That's done with a Doppler device, like you see in the picture here. This is done in the doctor's offices and sometimes in the hospital when you just need a quick check of what the fetal heart rate is. You're basically just confirming it's there and that it's beating steadily. You can also use an external fetal monitor, like you see on this slide. Here you have a device that uses two different probes. One sensor detects the fetal heart rate. The other detects the uterine contractions. This type of fetal monitoring can be done in the doctor's office to do a non-stress test. It is the device of choice in the hospitals for monitoring women in labor. The goal of fetal monitoring is basically to make sure that the fetus is okay and is able to tolerate contractions during labor. The fetal heart rate is a reflection of the fetus's oxygenation status. So that's why we're looking at it, and we'll be watching for the different patterns. When you're looking at a fetal heart rate strip, you need to know what you're looking at. So this sample in front of you has two portions. The upper portion is the fetal heart rate recording. The lower portion is the recording of the contractions. Now this strip is really nice and has shaded in blue the normal baseline for the fetal heart rate. You see the nice red lines that delineate each minute that passes. You'll notice between each minute there's also subdivisions. There's 6 subdivisions in each minute. Each a little box there represents 10 seconds. We'll just touch on some of the basics of terminology. Baseline is the normal fetal heart rate, and it is a range from between 110 and 160. So below 110, it would be considered fetal bradycardia. Above 160 would be considered fetal tachycardia. Variability is defined as the fluctuations in the baseline that are irregular in amplitude and frequency. They are actually the most important predictor of adequate fetal oxygenation and fetal reserve during labor. In addition to baseline and variability, we're also looking at the fetal heart rate for accelerations and decelerations. Now, accelerations are abrupt increases of the fetal heart rate above baseline. They should be at least 15 beats over baseline and last for at least 15 seconds, but not greater than 2 minutes. Decelerations, as you might guess, are decreases in the fetal heart rate from the baseline, and there are several types of those. An early deceleration is a gradual decrease in the fetal heart rate that mirrors the contraction. The variable deceleration is an abrupt decrease in fetal heart rate and is at least greater than 15 beats per minute and less than 2 minutes in duration. Late decelerations are a gradual decrease in the fetal heart rate from baseline. They're called late decelerations because they start after the contraction is already in progress. You cannot accurately assess fetal heart rate without also assessing uterine contractions. Interpretation of uterine contractions includes assessment of the frequency, duration, intensity, and resting tone, and can be monitored by palpation or with the external fetal monitor. The normal contraction pattern is 5 or less contractions in a 10-minute window when averaged over 30 minutes. If you're having more than 5 contractions every 10 minutes, it's called tachysystole. This picture from your book gives you a good visualization of the different components of uterine contractions. This is what your typical fetal heart rate monitor strip looks like. And this one you can see some accelerations there in the fetal heart rate and a couple uterine contractions. Now, the easiest way to remember the details about fetal accelerations and decelerations is to remember the mnemonic fetal chop. So when you have a variable deceleration, that abrupt drop that's not necessarily related to a contraction, it's due to cord compression. An early deceleration is due to head compression. Those accelerations, those increases above baseline, they mean everything's A-OK. We like to see those. Late decelerations are not a good sign. They signal placental insufficiency, which means that the fetus might not have enough oxygen reserves to labor through a vaginal delivery. I did include a link to a Picmonic presentation I like. It worked for me when I added it to the slide. Hopefully it will for you. If not, Google and try it if you like. So here's a fetal monitor strip that shows the early decelerations occurring with the contractions. And again, these signal head compression. Variable decels are easy to spot because they usually have that abrupt and jagged appearance that you see on the screen in this fetal monitoring strip. Late decelerations have that gradual dip, and that dip doesn't start with the contraction. It starts after the contraction's already in progress. So the last term we need to talk about is variability. Remember, variability is those fluctuations in the fetal heart rate baseline. Variability is the most important predictor of adequate fetal oxygenation and fetal reserve during labor. Moderate variability of 6 to 25 beats per minute is a strong indicator of fetal well-being at the time that it's observed. So you want to see a lot of moderate variability versus absent or minimal. Now, absent and minimal can occur during fetal sleep and sometimes with maternal meds, especially opioids given to the mother for pain. But sometimes they are indicators of fetal acidosis. Marked variability is greater than 25 beats per minute and can sometimes be associated with fetal movement. Now, this has just been a review of some of the basics of fetal heart rate assessment. Don't stress. It'll all come together when we work with it in class. But as always, if you have any questions, feel free to email me.